And Dr. Betsy Rosenthal, a member of our board, a practicing dermatologist in Westchester County, is going to be the person who kind of leads off and puts together, moderates this panel of people who went up to Toronto, Canada to look at the Canadian healthcare system. So let me turn things over to Betsy.
Hello. First, I'll tell you how this trip to Canada happened. I was at the Denver meeting, the national meeting in Denver last fall, and there were several Canadian doctors there, and they were talking about what happens when they speak to American doctors, just describing their day at work. And they said for the American doctors in the audience, this was a jaw-dropping experience because they described what they did and mostly what they didn't spend their time doing, fighting with insurance companies to get paid. And so we thought, well, I thought, and some of us thought it would be fun to go actually to Canada and actually sit in doctors' offices and see how it worked in actual fact rather than the theoretical things that we've all heard about and read about. So I was given the name of Danielle Martin, who's the head of a group called Canadian Doctors for Medicare, and they are a group of doctors who are working very hard to keep their Medicare system as it is, because there they, believe it or not, have movements to try and privatize it. And I got in touch with her and told her what the plan was, that we'd like to bring a group of doctors up there to see what their system was like, and she said fine, and planned a day for us that was absolutely chock full of visits. She did a wonderful job. It took several months. We fixed the date in April. We had 8 people from PNHP, not all physicians, but mostly physicians. And she had a day absolutely chock full of activities for us. First she gave us, and it was all concentrated around the central area of Toronto where most of the hospitals are, and particularly Women's Hospital. She started off with a little talk about what their system is like, how it happened and how it developed. And every speaker that she had and every person that she had us meet with were really top-notch people in their fields, and they were very, very informative and very interesting. So we had all day long different, mostly academic doctors talking to us. And then in the afternoon, we were paired with doctors in our specialty, and we actually got and shadowed them and stayed with them in their offices and saw how they interacted with their patients. And we also, by the way, could speak to the patients and ask them. In fact, during the whole day, we could often ask patients, what do you think of your system? You know, how would you contrast it with ours? And they're all thinking that we're totally crazy in the United States. Anyway, it was a really interesting day, packed full of very interesting talks. And then at the end of the day, we had a dinner where we got to meet everybody and talk to them, and everybody got to talk to everybody else. It was really great. The next day, we had some more talks. Dr. Arlene Bierman, who's an American doctor who's been working in Canada for 6 years. She's a researcher. She's an academic. She arranged for very interesting talks. And then we went out to the suburbs, and we met with a doctor who is a primary care physician, sort of in the trenches, right in the suburban area, and he talked to us for an hour. He really gave us an hour of his time to tell us all about what his day is like, what his work is like, how it's improved over the years. It was all really, really very interesting. And I'll just give you a few of my impressions, and then I'll let everybody else talk. First of all, the first strong impression I got was how the Canadians, what we think is so wonderful about their system, that is that nobody has to worry about paying for health care. Everybody has access to doctors regardless of how much money they make, whether they're employed, whether not employed. Sure, there's inequities, there's problems with access in rural areas, there's lots of things, but that is true for all of them. And the people all get treated the same. It's not like some people get Cadillac plans and other people get, you know, worker peon plans. It's all the same. So, but that fact and the fact that that happens all the time they take it for granted. They can't remember anything else. Their plan started in 1968, so they really don't remember anything else, most of them. And they just take that for granted, and they don't talk about that at all, that part of it. They don't talk about it at all. All they talk about is what's wrong with their system. Well, we could do this better, we could do that better, we don't, the medicines are still too expensive, they're not covered, various things. So the basic thing that we're fighting so hard to get, that they've had for a long time, they just are so used to. That was very striking. We also found out that the doctors aren't paid as poorly as we've been led to believe. Some of them work very, very hard. Some of them, you might say, are overworked. Most of them were pretty contented with their work situation, although there are problems. And that was very interesting. We spoke to many different kinds of doctors. My husband and I actually went a few days earlier and visited with some friends who had a daughter who was a dermatologist, and she introduced us to a lot of her friends, doctors, so we got lots of different impressions. It was really, really fascinating. They do have problems. They have not enough specialists. It takes a long time to get an appointment with a specialist. In rural areas, there's lack of access like there is here. And there's waiting times for certain elective procedures. They're all working very much on that. One more impression I got, though, was that when a lot of the people that we spoke to were innovators. They were trying new things. They were trying new ways to improve their system. And it was very apparent that in a unified system that they have, it's much easier to do that kind of innovative research and then to apply it. Whereas in our very fragmented, disjointed system, it's much harder to do that kind of innovation. That's all I'm going to say, and I will turn it over to my favorite doctor, Dr. Sam Rosenthal.
Thank you, Betsy, for giving my talk. I'd like to start off by telling a story. Please forgive me, that did not occur during this trip. This happened last summer. We were in the Berkshires watching a musical performance by a very talented performer by the name of Milton. You should all get to see him sometime. And we were the audience was sitting at tables. The next table over there were two couples. They were speaking with each other, and they had obvious Canadian accents. And Betsy overcame her usual shyness and got up, went over to the table and said, I can tell that you're Canadians. Would you please tell me what you think of your medical system? And one of the men told the following story. In the year before, he had developed some abdominal pain. He went to the nearest health facility. I don't know exactly what the facility was. The doctor that he saw diagnosed a leaking abdominal aortic aneurysm. He was immediately loaded into an ambulance. The doctor and the nurse accompanied him in the ambulance. They rode 60 miles to the referral hospital in Halifax. He was met immediately at the hospital. After a prompt workup, he had surgery, and there he was a year later telling the story. And what did he think of the Canadian health care system? He thought it was terrific. Okay. Betsy asked him at the end of this, what kind of a bill did you receive? And he said, bill? I didn't receive any bill for this. And I just want to make a small point about this. The reason that he didn't have to pay anything was because the province of Nova Scotia, in which he lived, decided not to charge him for those services. There actually is no such thing as a Canadian National Health Service. The Canadian Health Care Act sets up standards for treatment throughout Canada, but it's completely up to the provinces to administer this treatment, and you will find variation from province to province in the way medication is given. But nevertheless, I mean, no matter where you live in Canada, if you are a citizen or if you're just a legal resident of Canada and some medical emergency comes up and you go to the nearest healthcare facility, you don't have to present much more than your Canadian healthcare identification card, and you're going to get immediate treatment. The treatment is going to be comparable to what you would get in the United States under a similar situation. And when you get done with the whole thing, no matter what they've had to do to you, the bill that you're going to get is going to be, let's say, modest, to say the least. So, as Betsy said, we expected that when we talked to people when we went to Toronto, they would tell us how overjoyed they were with their system, and that's not exactly what we got. I had a chance to interview a man who was in his 80s, was in the hospital, Mount Sinai Hospital in Toronto. He was in the hospital because of worsening of his pulmonary disease. And I asked him what did he think of his healthcare system, and the first thing he said was, oh, well, it's okay. So I said, do you have a primary care doctor? Yes. Do you like the primary care doctor? Yes. Do you like the treatment that you've gotten in this hospital? Yes. Can you remember the days when there wasn't a Canadian healthcare system? Do you want to go back there? Emphatically, no. But when I developed my cardiac and pulmonary condition, I had to wait for more than 6 months before I could get a specialist to see me, and that really bothered him. This was kind of curious to me because my practice of medicine, I'm in the United States what you would call I do general internal medicine, and I do outpatient medicine. And I found out that there aren't many like me in Canada, maybe none like me. People that do general internal medicine in Canada are hospitalists. So there's nobody in between a primary care physician and a specialist. In my hospital, this guy's pulmonary and cardiac disease, I guess I would have to handle it from day to day. Once a year, I might send him to a cardiologist or a pulmonologist. He certainly would have to see one of them if he needed a procedure like a cardiac catheterization or a bronchoscopy, but otherwise it's up to me to take care of it. But I really couldn't get to feel that I was a really hotshot kind of guy when I heard what primary care doctors do in Canada. I mean, they really do everything. We heard about primary care physicians who deliver babies. We heard about primary care physicians who treat infants in their first year of life. I mean, they do things like the things that I couldn't conceive of possibly doing. But the patient that I spoke to was right. I mean, there really is a delay in getting specialists, and there are certain elective surgical procedures that there just is a waiting list for. At the presentation by Danielle Martin, we were shown how there was a nationwide effort to reduce the waiting time for certain procedures. The ones that she mentioned were hip surgery, knee surgery, cataract surgery, CAT scans, seeing a cardiology consultant, seeing a cancer consultant. And she showed pretty good evidence that they had really reduced the waiting times. But still, I mean, for some of the procedures, the waiting times were still greater than they would be in the United States. But one point that I took from this, and Betsy mentioned this, is here you have a problem that faces the system, and the entire system faces the problem. The entire nation is looking at the problem, and they're trying to come up with some solutions for it. In our country, where you have fragmented medical care, where you have all kinds of separate interests, I mean, that's just not going to happen. What about why can't Canadians do what we can do? Well, I mean, the answer is obviously cost. I mean, cost is the 800-pound gorilla that's lurking in the closet when you talk about trying to provide medical care. I mean, get right down to it, costs a lot less to pay for a primary care provider than it does for a cardiologist. Canadians spend, on the average, 5/8 of what Americans spend for medical care. 5/8. You can measure that in terms of expenditure as a percentage of the gross domestic product, or as what is spent on an individual for medical care in the course of the year. 5/8, 60%, and that's a substantial difference in what we pay. Betsy mentioned that there is a movement in Canada to try and go back to privatizing medicine. One of the big arguments that the people who are arguing for reversing Medicare in Canada is that there has been a tremendous increase in medical costs. Danielle Martin showed us that when it comes to the part of medical care that the government provides, for example, the government provides 90% of hospital care, pays for 90% of hospital care in Canada, and almost 100% of physician salaries. That proportion is not increasing. I mean, it's staying about the same. If you measure that, for example, as a proportion of the total government expenditure, it's staying about the same. What is increasing in Canada is the non-governmental part of medical expense. And let me try and explain that. About 70% of medical care in Canada is paid for by the government plan. The other 30% consists of virtually all dental care, a lot of eye procedures, surgery, which is considered non-essential, like cosmetic surgery, and most importantly, drugs. Those are not necessarily covered by the Canadian system. And that 30% is the part which is really going up in cost. So let me tell you another story which is not from our trip. Please forgive me. I went back to work on the day that I came home from Canada, and I didn't plan this, but the first patient that I saw was a guy who lives in Nova Scotia. I work at the Veterans Hospital. He's an American, a veteran of the American Armed Forces. He moved to Canada several years ago because it's much cheaper to live there. Those were the days when you could buy $3 Canadian for 2 US ones, I guess. But he lives in a small town in Canada. And I asked him, what do you think of the kind of medical care that you're getting there? And he gave me the same kind of response. It's okay, but. And he talked about his primary care provider, who he really liked a lot and who did all kinds of unusual things, like, for example, minor surgery in his office. But this guy comes down once a year to visit with his daughter, who lives in Scarsdale. And when he comes down, he goes to see his cardiologist at Cornell Medical Center, and he comes to see me at the VA to get his prescriptions. There is no cardiologist in a small town or nearby where he lives, and I guess he figures it's just as easy to go to Manhattan as it is to Halifax to see a cardiologist. But you know, what is so great about the VA prescription plan that he can't get in Canada? Let me try and explain what VA prescriptions are like. The VA considers the price of a prescription a handling fee. It has nothing to do with the cost of a drug. The price for a bottle of aspirins is the same price as a bottle of the most expensive cancer chemotherapy drug. Not only that, but if you don't have a high enough income to pay for it, the cost is zero. The VA has a national formulary, and that means that we can, you know, say you have a certain indication like stomach hyperacidity or blood pressure, there may be 10 different drugs for that particular indication. The VA will have only 1 or 2, and the ones that it'll have will likely be generics, and they'll likely be the least expensive ones that are available. If you want something that's not on the formulary, you can get it, but you have to make a written or a computer-entered request for it, and you have to justify your request by saying either no equivalent drug is available on the formulary, or else the patient has had an adverse reaction to something that's on the formulary. Another very important feature of the VA system is that the VA buys drugs in quantity. This is a system that has hundreds of medical centers throughout the country. It's got a lot of clout, and it deals with the drug companies to negotiate prices for whatever it is that it buys. And in Canada, the same thing happens. The government does negotiate with drug companies, and prices for drugs in Canada are the result of a negotiation between the government and the drug companies, and that's why for certain high-ticket drugs, I mean, the price is much less in Canada than it is in the United States. So anyway, what kind of prescription coverage do Canadians get? It varies from province to province, and we were told that in the northeast, in the eastern provinces, medical care is prescription care is worst, and that would include Nova Scotia, I guess. We talked to some physicians in Ontario. In Ontario, it's slightly better. For senior citizens, there is a system which is roughly equivalent to what the VA has, and they do have a system of free prescriptions for indigent people. But any place in Canada, you're going to get a different kind of a situation, and it might be quite costly. So let me bring this to a close by saying Canada has gotten rid of for-profit health insurance, and the result of that is, for real serious problems, there isn't a problem in Canada. People get treated and get taken care of well. Furthermore, there are problems in the system, but by getting the competing interests that there are in the United States out of the way, there's a possibility of dialogue occurring and change being made, either on a regional level, a province level, or even on a countrywide level. And I believe, as all of you I'm sure believe, this is the first step that we have to take. We have to get rid of for-profit health insurance. But we have to be aware of the fact that when we get rid of for-profit health care, we've got a whole other level of problems that we're going to have to face. And that the big factor in those problems is, the biggest factor is going to be cost. Thank you.
Been a really terrific summary so far. There were a couple things that really surprised and pleased me when we were there. One was the sort of general attitude of physicians. Here there's sort of a conflictual relationship between doctors and the insurance companies, and the sort of pushback in terms of trying to get what you want. And there it was very striking that physicians that we met with felt they were sort of working together with the province to solve some of these problems. And it was a very positive feeling. And I think Carol may talk about some of that when she gets up. But for example, in the waiting times, they've looked to see, do we need more specialists? And they hired more cardiac surgeons to do cabbages. Then stents came out and they realized, oh, we got too many cardiac surgeons. We have to adjust that. So it's not perfect in terms of the way they approach it, but it's very different from here, where I generally been a really terrific summary so far. There were a couple things that really surprised and pleased me when we were there. One was the sort of general attitude of physicians. Here there's sort of a conflictual relationship between doctors and the insurance companies, and the sort of pushback in terms of trying to get what you want. And there it was very striking that physicians that we met with felt they were sort of working together with the province to solve some of these problems. And it was a very positive feeling. And I think Carol may talk about some of that when she gets up. But for example, in the waiting times, they've looked to see, do we need more specialists? And they hired more cardiac surgeons to do cabbages. Then stents came out and they realized, oh, we got too many cardiac surgeons. We have to adjust that. So it's not perfect in terms of the way they approach it, but it's very different from here, where I generally don't get the sense that, suppose there's there's long ER waiting times throughout the city, getting beds and all of that. They have a similar problem. And so they're looking at it. How can we make decisions within 8 hours? Can we get the floors to discharge patients faster? Do we need more nursing home beds? So you feel like there's a very collaborative effort to solve the problems that are continuing to come up in any country in medicine, but that here there's so many different factors at work that I often feel they're at cross purposes, where the hospital wants to stay full so they can stay competitive, and then the insurance companies don't want someone to get a certain kind of health care, and then the standard of care is that, oh, you got to see people every 10 or 15 minutes. So you have all these different competing factors, whereas there I felt that there was an agreement that what we want is really to provide good care to patients as well as we can. And here, let's try these different strategies. Some of them were doing research on projects. Carol, I think, is going to talk about discharge, some of the discharge things, to try to help people from bouncing back to hospitals. But it was the kind of environment where you thought, gee, it'd be nice to work in that sort of setting where people asked for your input and said, well, how do you think we can solve this? How should we improve this? How can we give patients better follow-up care? So that was a big difference. The other that Sam talked about, but which I didn't fully realize, is that the GPs in Canada who go to medical school and then have 2 years of residency handle everyone. You cannot see anyone else before seeing your GP. So the GPs basically run everything, all pediatric care, all OBGYN, all internal medicine, minor surgery. They do all of it. So so as Sam said, there are no general internists. I mean, every internist, pediatrician, OBGYN are considered specialists that you have to get a referral to see in order for them to handle a problem of yours that's more complicated than your GP can handle. And I think there's some good parts to it. I think it completely overburdens in some way the whole GP system and sets up this structure that's a little bit artificial. But it does kind of change people's orientation. in the United States, oftentimes a person's first reaction is to see a specialist. Oh, I got a stomach ache, can I have a referral to the gastroenterologist? Whereas there, I was talking to a doctor who just had a baby, and I said, oh, who takes care of the baby? Oh, the GP. So everything is done by the GPs, and I think it somewhat keeps down the cost of medicine, but it's a very different role. So I'm a primary care internist, so I see all kinds of internal medicine as well as sort of minor orthopedic things like that. But there, internists really work generally out of a hospital and out of an academic medical center. And when I followed a doctor during the afternoon who was an internist, she was working in the hospital, and they were seeing patients that had been referred in by the GPs, and there was a lot of variability in terms of what the GP managed and what they refer on to the internist to manage. But that part of the system is absolutely different structurally than ours, and was kind of an interesting thing to see. So I'm going to close with that because I know we have a couple more people. But it was a fascinating visit, and just the difference in attitude, I guess, what really affected me. The people seemed quite happy to be working in a system that they felt was compatible with how they viewed patients being taken care of, that everyone was going to get care and as good a care as they could provide.
Okay, next is Dr. Carol Schneebaum.
Hi, I'm also a retired primary care doc. I practiced at Montefiore Hospital at the medical group and was always a salaried physician and somewhat protected from the economic environment, though, as the years went by. And when I retired, by the time I retired in 2005, I definitely wasn't as protected as I had been. Nonetheless, I do want to talk about what Mary mentioned, the virtual ward, and a little bit about how consultants are extended by some of the innovative ways that they deal with them. I was enormously struck and really touched when I had the experience in the afternoon of the first day of being in Danielle Martin's office. She was the doctor who's president of Canadian Doctors for Medicare, and she had arranged for 4 of her patients to come in basically to speak to me. Well, 3 of them specifically for that, and then there was one visit of a newborn, a 10-day-old, which was just for the pleasure of seeing a healthy 10-day-old and happy parents, I think, for both her and for me. I was really moved by the palpable absence of money in the room. And I couldn't put my finger on the facts, but it really made a difference. And I thought about that afterwards because I thought, I mean, the costs are a major factor for Canadian doctors, for the system, as they are here. Doctors are concerned about their incomes the way they are here. But those concerns are not between the doctor and the individual patient. Those are system concerns, and that's a hugely different thing. The patients I spoke to were really all very interesting. I wanted to mention, well, one fact was that Danielle, who's a primary care doctor, not an internist, had 3 patients who had very complicated medical histories. So what I was seeing about good care, about satisfied patients, was not just people who could go to the doctor for a sore throat without worrying about co-pays or something. This was really major reaching out of a healthcare system, and actually major reaching out of all the supporting services that we so often know we can't get for our patients. One of the patients was a severely disabled woman with spinal muscular atrophy, who had been wheelchair bound her whole life. She came in with her husband and her 3-year-old daughter. She was a full-time working journalist. She started out by saying she was very excited to see me because she wanted me to explain what the hell was going on in the United States. So once we established that I had the same question and wasn't going to help her on that one, we talked about what she had experienced from the system. For one thing, here was this delightful 3-year-old. She had been supported through a very difficult pregnancy, respiratory failure when she gave birth, and no one apparently had tried to discourage her from using all these resources of the system. In addition, she had a wheelchair that met her needs. She had help at home, full-time help at home. She got a check from the government and could hire whoever she chose, which I thought was extraordinary. And she compared the services that she got and the care that she got to the care that someone who she had been friendly with online through a support group who had a similar illness, who lived in South Carolina or North Carolina, what she had gotten. This lady was no longer alive. And the woman I was speaking to really felt that the lack of the support services that she herself experienced in Canada might well have contributed to this other woman's death. Whether that was true or not, it was clear that the quality of life that this woman I was speaking to was afforded had not been available to the American citizen. Again, it was very moving to listen to. So that was one thing. It really makes a difference when the money is not in the room that you're in with your doctor. The two things I want to mention briefly about innovation, I think the Canadian innovation is important because here you always hear that you need to have profit as an incentive for innovation. And there, the incentive is that you need to do it to make your system work, and it's a system that you're committed to. We had a presentation on something called the virtual ward. As here, you know, there's interest in discharging patients from hospital as soon as is medically reasonable, and in not having readmissions. And the virtual ward was set up to see how that would deal with this. It's not an idea that originated in Canada. I actually Googled it, and it's been done in England, certainly, maybe other places. But this was the first one, I believe, in Toronto. Patients at high risk of readmission, and there was a standardized instrument for assessing that, were admitted to the virtual ward for a period of probably 4 to 6 weeks until they were stabilized and could return completely to the care of their primary family physician. And the virtual ward had, they were aiming for 90 patients, I think they said. At this time they had somewhere between 45 and 60. It was a full-time doctor, nurses, care managers, a full-time pharmacist, and these people, the patients were their patients. They weren't in the hospital anymore. They could be seen at home. They could come into the hospital to be seen. And the thought was that, as opposed to here, where I know I certainly had the experience of seeing my patients kind of kicked out and left to fend for themselves in terms of social supports frequently, these people were being stabilized and watched over until they were okay in the community. And it was an exciting presentation, I thought. The other thing is the extension, because specialists are frequently in short supply, there are innovations in terms of maximizing the use of the consultants. And I did get to see that in a simple example. There was a pediatric problem that Dr. Martin was dealing with, and she said, we're going to get a consult from the pediatrician. And off we went down the hall, not with the patient, but she did a full presentation of the patient, and not all problems would be amenable to this as a system, but she presented the patient to the pediatrician. They had a discussion. It was 15 minutes, I would say. It sounded like a very reasonable and good way to handle this particular problem. Then they exchanged bits of paper, which had to do with the fact that this is a billed service that goes to the government. And this is done, clearly it's done with pediatricians. It's done with mental health consultants where there's a major scarcity. And it's just one way that people are trying to figure out how to do what needs to be done with the current resources at the same time that they are trying to improve the resources. So the bottom line is, for me, it was really a very inspiring visit. Nothing, wasn't perfect, but you know, I'm old enough to know that nothing is, so, and I wasn't surprised at that. But it was a great opportunity to see it. So, thank you.
Are you gonna, Paul, are you gonna read the letter from, statement from Len, or?
I don't think I need to. I mean, I think that you guys have kind of summarized it nicely.
Okay, we have one more presenter that, soon to be Dr. Maureen Miller, is a medical student. She was a medical student who won an essay contest and then got to go on the trip.
Anyway, my name is Maureen Miller. I'm a second-year medical student at NYU, and just wanted to thank Betsy and everyone again for inviting me. That, as Betsy mentioned, the way that I got on the trip is that I submitted an essay to a contest just explaining why I, as a student, am in support of single payer. So that essay, if you'd like to read it, I actually recorded an audio version of it at the website soundcloud.com/Maureen Miller, MaureenMill. Now, so you know, there's a little bit of a jokey introduction because I kind of have a sideline career in comedy writing, so it's like, it's a little bit tonally different from what you might expect, but then it becomes very serious and very moralistic. But I guess to start off, I'll try to be brief, and I'm a little bit out of sorts because I'm studying for my medical boards right now. I think it's kind of interesting, actually, starting on that self-deprecating note, because in terms of interviewing other medical students and trainees on the trip, you'd see that the young people in Canada seem to have that little bit of a self-defeating edge to the way that they speak, which is very unfortunate. It's unfortunately reminiscent of the way that a lot of students in America speak right now about the state of the country. Now, granted, it was right before the Canadian election, and so the outcome hadn't been determined. There was a lot of nervousness going on, but one of our student guides was a public health student that works in Toronto and was saying to us, like, I'm so worried about all this debt that I have that I want desperately to work as an activist in the healthcare system, and she was affiliated with the Canadian Medicare for All group, but then she said, like, I know I've got $11,000 a year to pay, and then I just thought, $11,000 a year, which of course is a tremendous amount of money, but then compared to America, where you've got students that are my classmates and I who have $30,000 to $40,000, you think like that's just a whole different playing field. And it really makes you think like about the severity of the problem that's going on in any kind of Western country right now in terms of the collapse of the social compact. But anyways, it's just kind of like a shocking thing, but in a way good, because the really pleasing thing about it was that the young people there were really invested in the idea of changing the system and saying that there is something wrong with this. This is not that we should be demonstrating more of a commitment to our fellow citizens. And that really the point of our civic project is to provide these services for people. So in speaking to one of the family physicians on the trip, the GPs that Mary was referring to before, he mentioned that in Canada, I guess, as one of the cost control incentives in the 1980s, they thought, well, we as a country can save on the tuition costs for medical students by not subsidizing as many of them to go to school. And so in the 1980s, they refused to enroll as many medical students in Canada, and now, surprise, they're facing a primary care crisis where they don't have enough family doctors to practice. And so then I asked him, well, is there interest then in students, and very much like you see in the US, where people want to go to medical school for with the idea behind them that we need to really restore this profession as really a civic duty to people. And he said, yeah, we see some of that. Like, we have the incentives to go into the rural healthcare projects or like to work in family care, but we really need to have some more of a government force behind it. That he said again that it varies by province, but there is interest in that. And it is very nice to know that organizations like the Canadian Medicare for All group exist in order to serve as really a social force for that, I guess. And so I mentioned the student debt issue, but in terms of looking toward the future, this family physician was also mentioning that one of the incentives to get people to continue to stay in primary care who might otherwise leave was to basically set up a merit pay system for certain chronic disease indicators. That, I mean, if the concern is that costs are going to be from heart disease or from diabetes, then they're going to start looking at your glycemic index numbers and saying, like, are you keeping X number of patients at a certain level? And so I don't remember what the cutoffs are off the top of my head, but then they said that they keep very scrupulous records trying to figure out how to get everybody down to like the HbA1c level that they want. But other than that, I guess I did do some of the shadowing, but the nice thing as a student is you can kind of play up that student role to a hilt and say, like, I don't know anything, you tell me. It's like really like allowing them to talk and give their very frank opinion about things. And so in terms of what they see as part of the future, there's a lot of interest, like there is here, in having patients learn how to self-educate a little bit better about the healthcare system. So we met with a doctor who kind of has set himself up as a guru named Dr. Mike. He writes for the Toronto Globe and Mail newspaper and has talked about a healthcare 2.0 system that he's set up among family practitioners so that they can give their patients healthcare information that's a little bit more user-friendly and very colorful and like to the point. Videos that you can watch online. They facilitate ways that you can ask questions to doctors, but maybe you're not necessarily doing that through a visit. So I mean, the interest in terms of how to reform primary care or like first family practice visits is very similar to here in ways that you wouldn't necessarily think of. And what's interesting about there that some of the other physicians in the group were alluding to before is that you don't see the same level of suspicion about corporate encroachment that you do in the American system. That in talking to this guy, he was saying, yeah, that it's really more of a collaborative effort with pharmaceutical companies or like with corporate sponsors. And we thought like that, well, that's interesting. They see it again as a partnership as opposed to like an adversarial means to an end. So, and sort of it was a really wonderful visit and I appreciated the chance to go. So anyway, thank you.
So, Betsy, let me just take back the opportunity. I know that Len Rodberg had written a piece about his experience there, and essentially I said that I would make a brief presentation since Len is not able to be with us tonight about that. But fundamentally, it is really almost what all of you have been saying, so I thought it was somewhat duplicative. That is to say, what truly impressed him about the Canadian healthcare system was that there wasn't, at the point of doctor-patient interaction, there wasn't any concern about money. That really didn't intrude in any way in the whole transaction. And he almost felt in some ways that was more important than the single-payer quality of the system, but it's the single-payer quality of the system that makes that possible. And so I just wanted to reflect that he actually did make this statement. We're certainly willing, Laurie can send it out to you if you want to read it, but fundamentally I think that all of you reflected a lot of what he had in his statement. So let's open up things to questions for the group. Yes, Larry.
Well, it's not so much a question as a comment. The point all of you touched on was this issue of scarcity. And I think it's essential that when we lobby and when we talk to people, we talk about the fact that if somebody brings up the fact that people wait for hip replacements in Canada, that a big reason for that is not the system, it's the fact that per capita, they have less ORs, less orthopedists, less CAT scanners, less procedure tools, toys, and you could argue that we have too many and that they're distributed in a lousy way, but it's really critical to remind people that if we pass this tomorrow, our orthopedists wouldn't actually disappear, our ORs wouldn't be shuttered, our CAT scanners wouldn't be boxed up and sent back to GE or wherever they came from. We would still have the resources that we have, and hopefully the system, as you also pointed out, would figure out a better way of distributing them. But separate from that, this scarcity issue, as people talk about in England all the time, it just wouldn't be in place in the United States. It wouldn't exist in the United States. So it's kind of a non-issue, and I think it's very important that we remind people of that.
Yes.
I'm a patient advocate at a community health center in Westchester County and a blossoming single-payer advocate. And you might not be able to speak as much to this given that you were more on the clinical physician side of things, but in the job that I do, I spend a lot of time, on the phone with caseworkers at the Department of Social Services who are in the Medicaid unit running Medicaid cases and, calling 1-800-Medicare. I've been on hold for, 40 minutes. So I'm wondering, did you get any sense of, actually on the administration of the insurance level, how that's done? I mean, I certainly want single payer, but I know that if I call, Empire Blue Cross Blue Shield, it's a different experience than calling Medicaid.
They don't call. Okay? What you do is, each patient has a card. And I actually took a photograph of the card for Ontario. It's different on each province. You present that card when you go to the doctor, and the government gets billed for the services that the doctor provided. And the doctors get paid. They actually get paid.
Right.
There's no fighting about that. I mean, in some ways, Medicare is like that because even though a lot of people think that private insurance pays more than Medicare, the difference is that Medicare actually pays you. Whereas private insurance theoretically pays you. They say they're going to pay you, and then they don't pay you. And then another month goes by, and then you have to resubmit the bill. And then they don't pay you again. And they keep doing this several times. Several months have gone by, you still have not been paid for the work that you did. The Medicare check arrived a long time ago for a patient on Medicare. And then the private company says, well, we agreed to pay you $100. I know we have a contract, but if you agree to take $70, we'll pay you now. Now being 4 or 5 months after they were supposed to pay you. So none of that happens. That just doesn't happen. You present the bill, it gets paid. There's very little denial of, it almost never happens. The billing department at at Toronto General Hospital, 3 people. 3 people. We saw a group of had like 6 doctors. They had one person who, a small part of her job was to do the billing. She had a lot of other things she had to do.
Another point was when we asked the doctors, well, who do you have to get permission from to do X, Y, or Z? They said you don't.
But on the patient side, that's true, because I mean, when I'm on the phone, it's because the patient, it's not because the doctor's trying to get paid, but I guess the patient, they just,
certain things are covered and certain things aren't covered, and it's the same everywhere, and everybody knows what those things are.
And
That's
so,
it. They're not gonna say, well, I want you to, you know, do a facelift for me. I mean, it's not gonna be covered.
do you know who, because you said there were like regional differences, you just sort of get an explanation from your.
Well, you live in your
local government.
province, so
This is your point.
No, it's public knowledge or it's covered in what's now.
Other question?
I
Yes?
would not have a job there.
Yeah. No, I know, it'd be easier.
Does Canada have a uniform medical record system?
No, not yet. They're anxious to figure it out, but they don't have one yet. Yes.
So the doctors, I'm still not clear, the doctors, they don't get a salary, they get paid per
It's
service.
different doctors are different systems, everybody's not the same, there are some doctors who get fee for service. The family practitioner that we spoke to who was in the suburbs had recently changed the salary. But that's not, it's not necessary to be one or the other, they can be set up in different ways. He liked the change from the fee for service to a salary, and also, as an incentive for doing that, all the family practitioners got raises, basically. So he was making more money in the last few years than he had prior.
So the province provides a certain amount of money to medical centers, to groups of physicians, and individual entities can make their own decisions about what they're going to do. We, before we went on the major trip, we visited in the city of Peterborough, and there, innovating physician and medical administrator decided to combine all of the primary care in the city of Peterborough, which is a city of about 120,000, together, and they managed to negotiate that instead of doctors being paid fee for service, which is still the way the majority of doctors are paid in Canada, they would just get a lump sum grant, and they would pay the doctors a salary, and the doctors would take patients, capitated patients. They would each have a patient panel. Turned out, with the money that they got from the government, they were able to pay doctors a higher salary than what the average physician was getting. It was incentive for physicians to come into their area, actually, to practice.
When we walked into this guy's office, there were several different flying pigs, pictures of them and statues of them, and it was clear to us what that was all about. When he proposed this about getting all the primary care doctors in this town of Peterborough together in this plan, it was a very go-getting, innovative administrator and a chief of medicine at the hospital who got together to do this. They said, well, all the doctors will agree on this when pigs can fly. And when we were there, it had been accomplished.
Yes, over here.
Two questions. Maybe you could just comment on the malpractice system in Canada. And the other is, trying to give us a feeling or a comparison about the quality of life of physicians. Not academic, but I'm saying people who are actually out there in the trenches or practicing, be they specialists or primary care. In terms of comparison with American physicians, I mean, are they in the culture, or do they hold a approximately the same place? And finally, what about their lifestyle in terms of their satisfaction overall? Are their hours in general shorter? Do they have more vacation time? I think most physicians in this country, for one reason or another, including myself, are dissatisfied for a variety of different reasons, but dissatisfied. I know there's a lot.
Okay, first, I don't know very much about the malpractice. I do know that the rates are much lower than here, and the number of suits is much, much lower. That's all I know.
The other piece that affects malpractice majorly in a system like Canada is there's no malpractice rewards for the cost of future medical care, which is the majority of the cost of malpractice. You have a baby that's born, there's some problem. Well, that's going to be covered in Canada for the rest of your life. So there's a lot less, it's more sort of pain and suffering than it is the cost of future care, which is sort of a major thing in the United States. So it's much, much cheaper, and the Canadians are less litigious.
And we spoke to several different doctors about the quality of life. I mean, we asked them about that. The doctor, the private doctor, the family care doctor in the suburbs that we saw, he was more satisfied with his quality of life recently than he had been prior, because he felt that he was working a little bit less and getting paid a lot more. He did feel overworked, and he did work long hours, and he didn't have that much vacation. I would say he took maybe, what, 3 or 4 weeks a year tops, and he worked long hours.
3 or 4 weeks a year.
A lot of doctors take more than that. Some do, some don't. He felt, though, one thing that I think that most doctors here feel is the tremendous, horrible burden of the hassles with the insurance companies and fighting to get paid and all that, and they don't have any of that. They don't have that, period. So whatever hassles they have, it's not that. Yes, it is. We spoke to, I think that's what's going to make more and more doctors who were afraid with single payer they wouldn't make enough money, but if they could be relieved of all that burden, their life would be much nicer. We spoke to several young doctors, this dermatologist who was our friend's daughter. She worked, she churned out a lot of patients. I mean, I as a dermatologist don't churn out nearly as many, but I'm not like most dermatologists and I don't make as much money. She made a lot of money. She didn't work terrible hours, and she had a lot of vacation time, but while she was at the office, she saw a lot of patients. And the thing that she didn't like was that there weren't enough dermatologists. I think she was the only dermatologist for this town of 100,000 people, and there were long waiting lists for her patients to see her. So once you got into her practice, you could get a fairly reasonable time, appointment in a reasonable time, but for a new patient, it was a very long list.
I thought there was also a big difference between the academic physicians and the GP we saw in the community, who was really working every day, seeing patients every 10, 15 minutes, every 10 minutes, all day long, taking call at night. They all had weekend hours. And the people who were academics in the hospitals did some clinical work, some medical student teaching, some research, and it felt like their hours were more regular.
Right.
One, because they generally weren't on call for emergencies because they were consultants rather than kind of the first line people. So there did seem to be
And
a
they got
significant...
paid well.
Yeah, there did seem to be a significant difference between academics and those kind of out in practice, which is somewhat true in the United States as well.
Well, we spoke to a couple of, a general family practice doctor in Peterborough, and she didn't seem quite as burdened as the other guy we spoke to. And we also spoke to emergency room doctors in Peterborough, and they seemed, wouldn't you say they seemed happy with their lot?
I think we should take one more question at this point. Mary, did you have a question?
I did, but Ron had hand up first.
Oh.
Well, I keep
How
falling
about 2
asleep
more
someday.
questions?
Yeah,
All right,
Ask them
a
both.
question about, is there any sense of quality review amongst the physicians? Anything like peer review from the 1980s we used to have here, or the quality assurance things that Medicare is trying to push through?
Well, they certainly, among the GPs, they certainly had guidelines that they had to meet for chronic problems in terms of blood pressure levels, hemoglobin A1C, things like that, and they had a hand-in information on it. But we didn't talk to them a lot about that element of medicine. But I
There was
presume
one
that
place
it
where they
is.
talked about the shadow billing, remember that?
Oh, that was to see if fee-for-service, how it,
No, I think part of the
Balance
so-called shadow billing was to see what they were doing, as far as were they doing the right thing, but
no,
they.
I don't think so. But they did have incentive payment for preventive care, meeting preventive care standards, et cetera. And I don't think we really talked to people about QI stuff, QA and QI, but my sense is that it was being done in the hospitals.
And it's much easier to
Much
follow
easier to
since
do
they're all
it,
part of
yeah.
the same system. It's sort of like Medicare here, where you can get a better handle on it than you can with the hundreds of different private insurance companies. But we didn't spend much time on it.
But they did use it to compare, like how many patient visits one doctor would have for the same problem as another doctor. I think that's one of the things they used that shadow billing for, rather than just payment.
I just want to say one more quick thing. The fragmentation in this country, not only with the medical, in the healthcare system, but in general, because I do some volunteer work on children's issues, it's so fragmented, everything. Services come from here, there, and the other place. The computer systems, where there are systems, don't speak to each other. And I think one thing about this system was, though it's not uniform across the country, etc., it didn't have that same sense of being broken up. And of course, then you have a huge difference in how you can figure out what's really going on.
Well, let me just say, number one, I'd like to hear what the election results showed. I bet it was close.
Hang in there. Thank you so much to the panelists, and thank you to our members for voting. I would like to congratulate all our renominated current board members, and also especially congratulations to Mary Doerr, Adam Gaffney, our
Secondly, let me say that this is the last forum for this academic year. Our next forum will actually be in September, and certainly if you signed up on the sheet that went around, we will be notifying you about that. There is an event during June that you're all invited to